Good afternoon, everyone, and welcome to day one of the November Culturally Competent Conversations for Equity and Belongingness Summit, where we are focused in these 2 days on improving the accessibility of equity, belongingness, and inclusion initiatives in our talent and workforce pipelines. So with that being said, this is why this session is so timely and so relevant, because we have an expert here to talk about disability and ableism in the healthcare space. Now, before I introduce our expert, Lexie, quick housekeeping notes. Whether you're watching on YouTube, LinkedIn, or Facebook, and whether you're watching this live or later, please make sure that if you have any questions, drop them in the comments. We are monitoring all channels, and we will make sure that we get to your questions. And if you're watching this later, we will make sure that Lexie gets access to your questions so she can answer them for you. I'd love to take a moment to thank our partners who are walking this walk with us to make this possible and to make this accessible to all of you. So a huge thank you to Catchwords powered by EcoFiles, Achieve Podcast, Core Magazine, Aura Nexus, 30 Friends, Wistia, and Nielsen. And now it is my absolute pleasure to tell you a little bit about our expert who's going to be talking to us in this session. Her name is Lubna Baig, and she's fondly known in her communities as Lexie. Lexie is a radiology professional and SMRT on the SMRT Global Relations Board and the owner and radiology educator at MRI Buzz. Lubna Baig, BSRT-MR, I'll let her explain that when she talks to you, is multi-credentialed in radiography and MRI, holding over 2 baccalaureate degrees, with an additional background in pre-medicine from Loyola University Chicago and the University of Wisconsin-Milwaukee. While in the field, Lexie authored many articles endorsing her colleagues and dear friends' various educational programs and symposia, such as those presented by prominent healthcare leaders such as Tobias Gilk, Dr. Laura Vasquez, Dr. Catherine Westbrook, and Dr. John Talbot, Dr. Frank Shellick, William Faulkner, Kristen Harrington, and Dr. Emmanuel Canal. In addition to being an imaging specialist, Lexie co-owns MRI Buzz LLC with her close friend, Matt Redderer. She's also an avid MR safety advocate and speaker and hosts her own web series, Let's Talk MR Safety with Lexie, on multiple social media channels. Currently, she also serves on the Society for MR Radiographers and Technologists, SMRT, a section of the International Society for Magnetic Resonance in Medicine, ISMRM, Global Relations Board. Furthermore, Lexie continues to author pending academic papers and or assist colleagues with such papers and presentations, and is also pursuing higher academic and educational prospects at UW-Milwaukee. So without further ado, it is my absolute pleasure to bring to you Lexie. Lexie, the stage is yours.
Yeah, hey everyone, thank you for having me, Dr. AJ. I'm so elated to be here and talk on disability and ableism in healthcare. Before I start, I would like to thank my parents, my siblings, my business partner, Matt Redderer. I hope you're out there and watching me. My dearest friend, Julie Duncan, and also my mentor, Dr. Emmanuel Canal, the president of SMRT, Dr. Nancy Bellick, my close friend, the director of Imaging Sciences Program at Rush University, Dr. Laura Vasquez, and also all those, who have supported me and contributed to my success in radiology. Thank you, everyone. And I'm elated to talk on disability and ableism in healthcare. All right. Dr. AJ, I'm stuck here.
Looks like we lost Lexie, but technical difficulties happen, so please give us 1 minute, and I'm sure she'll be back. In the meanwhile, I am going to put sign-in sheet for Lexie's session in the chat, so please make sure that you sign into this session, and at the end of it, as usual, you will get a survey so that we can get your thoughts on what you thought about Lexie's session. And there she is.
All right. Hey, Dr. AJ, I don't know what happened to my slide, and it just locked me out.
Oh, that's okay. Do you want to try one more time, or would you like me to pull them up for you?
All right. So I'm trying to close this window. It's not closing. So it's just
No problem. We will. I'm going to pull up the slides right now.
Right.
How about this? How about you introduce yourself, and in the meanwhile, I'll pull up the slides, and when we're ready, we'll go.
Okay. Thing is, I need to be able to manipulate the slides on my own.
I see.
So, I need to go over the slides on my own. So I need to be sharing the screen.
Okay. So
that's what I need to do, but I'm unable to do that at the moment.
Okay. You can keep telling me to move the slides, and I can.
I hear a lot of feedback.
We are having some technical difficulties, folks. Give us a little bit of time. Lexie, you were on there twice. I have no problem sharing this.
Is everything okay?
Yes. There we go. Now I can share your screen for you. Please let me know when you want me to move through the slides, and I will do it for you.
All right, Dr. AJ, there's a lot of feedback. Hello. Hello.
Can you hear me, Lexie? Lexie, can you hear me?
I can't hear you. Can you please close the live stream?
Can you hear me?
What's that?
We are having technical difficulties, folks. We will be back. Lexie, can you hear me? Can you hear me now?
Yes, it's gone now. All right.
You kept logging on 2 times,
Right.
and that's what was causing it.
I need to really clarify this. When I pull up the slides, I want to be able to manipulate it myself. I'm not able to do that.
Okay.
Yeah, I want to be able to manipulate it myself because I don't have everything in my head. I need to go over the slides.
Yes.
So I'm going to share the screen now.
Yes.
Right. All right. Can you all hear me?
Yes.
Am I live?
Yes.
All right. So I'm going to go over the slides and just go on with the talk. All right. Okay, so everyone, I'm going to be speaking on disability and ableism in healthcare. Firstly, I would like to go over my background. My name is Lubna Baig, and I'm also known as Lexie in our professional circles in the MRI and radiology community, especially. I'm a licensed South American deaf and hard of hearing radiology professional and educator specializing in magnetic resonance imaging, or MRI. Radiology professionals are known to specialize in like different aspects of radiology, like MRI, CT, X-ray, ultrasound, and all of that. But I choose to specialize mostly in magnetic resonance imaging. I have a baccalaureate degree in biomedical sciences diagnostic imaging. I first went to a 2 year school for MRI, and then I pursued my degree further and got my baccalaureate degree. And currently, I'm pursuing like more higher grad and postgrad academic prospects and research opportunities specific to MRI and radiology. I'm also the owner of the radiology educational program MRI Buzz, which can be found online at www.mribuzz.com. I'm in partnership with the president of MR Safety Educational Company known as Right Advantage. Matthew Redver is my business partner at MRI Buzz. He also owns Right Advantage, which is like an MR safety examination test prep company. I'm also the honorary member of the Society for MR Radiographers and Technologists, which is the SMRT. It is a division of the International Society for Magnetic Resonance in Medicine, ISMRM. I'm on the Global Relations Board under the 2020 SMRT ISMRM President, Nancy Bellick. I also host my own radiology educational podcast series, Let's Talk MR Safety with Lexie. It's available on my official YouTube channel. I've also written like numerous articles endorsing imaging science education and events, that are hosted by many people who mentored me during my undergrad years and also my grad years in MRI and radiology. I'm also in a number of business collaborations with top radiology and healthcare leadership. For instance, if we go to the next slide, you can see all of my collaborations and networking events with different people like Dr. Emmanuel Canal, Dr. Catherine Westbrook, Dr. John Talbot, Dr. Jens Fay, Jim Stapino, Nancy Bellick, John Reyna, John Push. All of those are really top radiology, healthcare leadership now. And despite being deaf and hard of hearing, I found my way into MRI and radiology, into medicine and healthcare, and all of those wonderful people, they formed a significant part of my journey, and they left a lasting influence in the trajectory of my life and career, and I'm very thankful to them. So today we will be the top issues we will be covering are the obstacles that are faced by the deaf and hard of hearing in the healthcare setting, with an emphasis on BIPOC deaf hard of hearing healthcare workers. We are going to be talking about realizing the obstacles to inclusion for the deaf and hard of hearing and the nuances that intersectionalities of race and gender add to this. Then we are going to be talking about casual ableism and microaggressions faced by BIPOC deaf, hard of hearing workers in the professional setting. In particular, the spotlight on our speech patterns and accents. We are going to be trying and understanding the subtle ableist terms and casual ableism in the healthcare and corporate environment. Then, lastly, we are going to be talking about eradicating the racial and ableist barriers while working towards equity and inclusion in the healthcare setting. So, we are going to be focusing here on resolutions to provide room for authentic, intentional, equitable inclusion at the corporate level. So let's go over to a brief background in defining disability. Now, the American with Disabilities Act, which is the ADA, it defines an individual with a disability as a person who has a physical or mental impairment that substantially limits one or more major life activities. A person who has a history or record of such an impairment, or a person who is perceived by others as having such an impairment. So there's no exhaustive list of disabilities under ADA. Like, an individual with a disability can be defined as people with medical conditions such as those pertaining to deafness, blindness, diabetes, cancer, epilepsy, intellectual disabilities, partial or completely missing limbs, mobility impairments requiring the use of a wheelchair, autism, cerebral palsy, HIV infection, multiple sclerosis, muscular dystrophy, major depressive disorder, bipolar disorder, post traumatic stress disorder, obsessive compulsive disorder or OCD, schizophrenia. So these are all kinds of disabilities. But for this particular talk, we will be focusing on deafness based on my own experiences as a deaf and hard of hearing healthcare professional. Now, let's define the different terms that are applicable to the deaf and hard of hearing. So now we have deaf, we have hard of hearing, we have deafened, and we have hearing impaired. Now, the deaf usually refers to hearing loss so severe that there is very little or no functional hearing at all, like completely deaf. And the hard of hearing refers to a hearing loss where there may be enough residual hearing that an auditory device such as a hearing aid, cochlear implants, or FM system provides adequate assistance to process speech. Now, the late deafened, which is usually refers to people who became deaf as an adult and therefore face different challenges than those of a person who became deaf at birth or as a child. And that is where I come in. I fall under the late deafened category. I lost my hearing at the age of 11, and by that time, my speech was already developed. So I fall under the late deafened category. Now, the deafened, and hard of hearing individuals, they choose a variety of assistive listening devices like hearing aids, cochlear implants, to boost their hearing. Alternatively, or in addition, they may read lips, use sign language interpreters, and or captioning. Some people who are deaf or hard of hearing, they may have speech that is difficult to understand. They may have some form of speech impediment due to the inability to hear their own voice. That has been an issue with me too, especially when I first lost my hearing. But with time and practice, like I perfected my speech. I still struggle with it from time to time, but it's a process. And now there's this term known as hearing impaired that we often hear generally, like it's a general umbrella term that we keep on hearing impaired. It is often used to describe people with any degree of hearing loss, from mild to profound, including those who are completely deaf or just a little bit hard of hearing. But many individuals, including me, who are deaf or hard of hearing, we prefer the terms deaf and hard of hearing because they are considered to be more positive than the term hearing impaired. Like, because hearing impaired it implies more of a deficit or that something is wrong that makes a person less than whole. So I prefer that we not use the term hearing impaired to define a person who has a hearing disability. It's more positive to refer to them as deaf or hard of hearing. So we are going to discussion point one, which are obstacles faced by the deaf and hard of hearing in the healthcare setting. Now, 1 billion people, or 15% of the world's population experience some form of disability, and disability preference is higher in the developing countries. The one-fifth of the estimated global total, or between 110 million and 150 million, 190 million people experience significant disabilities. Now, the OSHA, which is the Occupational Safety and Health Administration, they state that in the United States alone, close to 28 million Americans have some level of hearing loss. And so these are the obstacles faced by the deaf and hard of hearing at the workplace or healthcare. Like mostly we see that in healthcare or in any workplace systems, they lack auditory operating systems and lack they actually just include the auditory operating systems, and they lack access to visual or tactile accommodation. It's I mean, phones are really not friends for people who are hard of hearing or people who are completely deaf, but that's the form of communication that is like rampant at the hospitals and in the workplace settings. Everything is auditory, and even for the training programs, you see there is classroom and speaker style training programs. There is no provision of closed captioning system or CART, which is known as the Communication Access Real-Time Translation or Sign Language Interpreters. Nothing of the sort can be seen to a great degree at the hospitals or general workplace. Um, Deaf and hard of hearing also struggle with developing or initiating solid co-worker relationships, mainly due to lack of awareness or education um, on with regards to people who do not have hearing loss or who are not deaf. They have some kind of resistance to adjusting communication methods geared towards the deaf and hard of hearing colleagues, simply because it's not in their job description. You know, they don't have to accommodate to you, it's what they feel. So well, mostly it sometimes gets you feel isolated, you feel marginalized. There's no inclusion for deaf and hard of hearing in the workplace culture where there is room for developing co-worker relationships. And the deaf and hard of hearing, this is a major problem in hospitals and all workplace. We lack real access to interpreters and assistive listening devices, closed captioning services. And in the COVID setting, like currently we are in the middle of the pandemic, the coronavirus pandemic, we do not have access to air masks. And many of us, the deaf, we rely on lip reading as, you know, as a primary communication method because not a lot of people know sign language. So we do not even have access to air masks. And those air masks have, you know, they actually help you visualize the lips. That is not available, and you know, that is a real barrier to people, the healthcare workers who are currently at the front lines, the deaf and hard of hearing healthcare workers who are currently at the front lines and trying to take care of COVID patients. And there's another major and significant obstacle to the deaf and hard of hearing in the healthcare setting. It's unavailability of loop building to people who wear hearing aids or cochlear implants. I happen to be part of two major organizations that are geared towards the deaf and hard of hearing. One is the Hearing Loss Association of America, the HLAA, and another is the American Medical Professionals with Hearing Loss, the AMPHL. So at one of the meetings, when I sat with the HLAA especially, a lot of them stated that looping would be the answer to many of the problems that they face in communicating with people at the workplace. Looping means, you know, it's kind of like most hearing aids, they have a telecoil, and if the buildings are kind of looped, they have a loop system like an FM system or a loop system. It actually eliminates background noise and helps the deaf and the hard of hearing hear clearer when they are in the workplace. And in the workplace, it often gets like, you know, chaotic, a lot of people talking at the same time. And if you add to that the background noises from the building and everything, it affects people who are trying to actually hear with the use of assistive listening devices like hearing aids and cochlear implants. So that's one major issue. And a lot of people in HLAA and AMPHL, they were citing this issue that they became a significant barrier to them. They needed low buildings at their workplace, at the hospitals, and everything to hear their employers or their colleagues clearer when trying to go about, daily routine at the workplace. Um, Also, there's no funds for the deaf and hard of hearing when it comes to the accommodations at the corporate level. Then I remember this one time. I mean, when I was in my undergrad year, and I was going to 3 clinical rotation at 3 different hospitals. I asked for sign language interpreters and other such accommodations, the use of cot and everything during lectures. Um, in my undergrad year, and I asked the AMPHL if they have such services for me, and they were really frank about this. With the fact that they are a non-profit and funding is a major issue for for most organizations to help the deaf and the hard of hearing access and obtain accommodation. So mostly we are left with just adjusting and work with our hospitals. So that is the so that's what we, instead of people who are not disabled or do not have a disability, instead of them accommodating to us, we are told to accommodate to them and adjust, compromise with what we have. And that can be a significant issue because a lot of us in the deaf and hard of hearing individuals are very qualified, highly qualified than even the most experienced people who do not have disability. And because of the lack of accommodations, we're not able to reach our full potential. And this is actually it's happening at the corporate level because they simply do not have funds to give us sign language interpreters, give us assistive listening devices, captioning services, any specialized equipment that can help us hear better at the workplace. So those are all the obstacles in generally that is applicable to all deaf and hard of hearing individuals in the healthcare and workplace setting. But then we also have deaf BIPOC healthcare workers and deaf women in medicine. Now, POC or people of color is a general umbrella term that collectively refers to all people of color, anyone who isn't white. BIPOC, which is it's actually a person first language, it refers to Black, Indigenous, and people of color. Now, historically, the deaf BIPOC healthcare workers, they have lacked access to information, and that information is mostly controlled by white deaf people. They have been deprived of equal access to education and language, being left out of outreach efforts by social services, and faced scores of systemic racism in healthcare access, insurance, healthcare information, general community information, and the like. Systemic racism is also very much alive and well within the deaf community. And there's one point to be noted: the deaf BIPOC are not a homogeneous group. Some are Christian, some are Muslim, some are atheist, some are gay or lesbian or transgender. Some are Latina, Caribbean, African American, Puerto Rican, Asian, Native, etc. etc. You have all sorts of deaf BIPOC healthcare workers and deaf BIPOC workers in general. And sometimes you have intersectional identities even within those cluster of deaf BIPOC workers. You have BIPOC with more than one identity, which is known as intersectional identity. Therefore, deaf Black people will automatically have intersectional identity. You see, and then we also have deaf BIPOC women. They are even more marginalized because historically women have always been underrepresented at the national, foundational, and executive levels. There's perceived stigma that is attached to women doing a man's job, and especially my industry, radiology. There are a lot of people who scan patients and all. They are known as technologists, and then there are people who are involved in the safety aspect, patient care and safety aspect of the industry. Some are involved in teaching, but most people in our industry, the radiology industry, especially my industry, MRI, most of them are men. And so there's a lot of perceived stigma, and it's like it's kind of like the scanning aspect of MRI is mostly referred to as a man's job, and it's like women cannot be techs. They can't. And there's the notion that women can be techs, women can scan, and they are usually weak and they can't lift heavy loads and stuff like that. Anything that is a part of like heavy duty physical work, that is a part of the job description in radiology. So that is the perceived stigma there. And deaf BIPOC women in general, they are passed over for opportunities. There's no equal pay, there's no equal opportunities. So these are all of the obstacles that are faced by the deaf and hard of hearing in the healthcare setting. Now, let's go a little bit deeper and talk about obstacles faced by the deaf and hard of hearing in MRI, which is basically my specialization. So now, compared to all other healthcare departments, MRI imaging departments are different. Now, 20 years ago, there was this incident. A 6-year-old boy, Michael Colombini, he succumbed to fatality from an incompatible ferromagnetic oxygen tank brought into the MR scan room by an anesthesiologist. So the American College of Radiology, or ACR, they formed a blue ribbon panel on MR safety, the forerunner of today's MR safety committee. So my mentor, Dr. Emmanuel Canal, he's a notable radiologist. He was asked to head that group. And then the ACR defined 4 safety zones in MRI facilities. You have zone 1, which is the general public area, like waiting room. Then you have zone 2, which is the patient screening area. You take the patient there, you ask questions like if they're carrying metal on them, their basic information, clarify their birth date, weight, and everything, any prior medical history, have them change into patient counts so that they can go and get themselves scanned on the scanning table into the MRI room. Then we have MRI Zone 3, which is this is the technologist workstation. It is where people who scan, the technologists, that it's their workstation. They sit there and they run the protocols. They run this MRI images. They scan the patients there. And then we have Zone 4. And this is a highly ferromagnetic area because MRI, compared to X-ray and CT, MRI utilizes magnets. They're really strong magnets. And so no metal or ferromagnetic metal can be allowed into the scan room. So that is a highly dangerous area, and this is why here is where the deaf and hard of hearing face significant obstacles. Because in the MRI Zone 4 scan room, absolutely you cannot take wear your hearing aid or cochlear implant or anything of the sort and go into the scan room, because otherwise the strong magnet attracts your hearing aid and the cochlear implant, and you could be stuck to the device, and there could be potential fatalities there. So the hearing aids, the assistive listening devices, captioning services, they are all incompatible with the MRI environment. So when techs, when they go into the Zone 4 MRI scan room, they have to remove their hearing aid or cochlear implant or whatever listening device they have, and then go and position the patient there, and then come back out. They may not be able to communicate with the patients effectively because they do not have any assistive listening devices. They can't take any assistive listening devices in there. Yes, there are some manufacturers that have developed MR conditional cochlear implant, but still they pose unique safety hazards regardless. So, all such devices that are unsafe or incompatible with the MR environment, they are given different labeling. Some devices are MR safe, some are MR conditional, or some are MR unsafe. That is completely. And those hearing aids, they fall under the category of MR unsafe, which means you cannot take them inside the MR scan room. Now, for the deaf radiology professionals working in MRI, they can't use hearing aids or assistive listening devices while they are scanning patients. And now in the COVID era, they also have the additional hurdle. They cannot read lips effectively because everyone is wearing masks now. And there is no provision of aid mask as PPE. There is no such N95 respirators or masks that help facilitate repeating available as of now. So, ergo, deaf or hard of hearing workers, they face increased exclusion and alienation at the workplace. So one of the things that I think that can resolve such issues, an effective resolution to such barriers would be we could follow the recently published ACR guideline. Now the ACR they recently published the 2020 MR safety manual where they stated that they recommended a guideline that there should be a minimum of 2 MR technologists in the MR environment whenever the patients are present. And this is actually significant and could be very much helpful for the deaf and hard of hearing MRI professional because they will have another person who is not deaf or hard of hearing helping them in communicating with the patient and working in the MR environment together. If you think about it, the healthcare in general is all about helping each other. So I think this is a really good guideline. The provision of having 2 MR techs, two radiology professionals working together, especially in a pandemic where everyone is wearing masks and deaf and hard of hearing workers cannot communicate effectively with the patients or with their co-workers and all of that. Um, I recently did a podcast with my mentor, Dr. Emmanuel Canal, and he also mentioned the same thing. This the guideline of having 2 MR technologists in the MR environment is also effective in that if a patient is facing any sort of emergency, like if he or she is having sudden cardiac arrest or or some kind of injury while getting scanned. If there are 2 MR technologists, they can communicate with each other within earshot, and they can help each other in giving and in a timely intervention to the patient who is facing distress or emergency while being scanned in the MRI scan room. So this is one method of removing such barriers that can alienate or exclude deaf or hard of hearing radiology professionals from working in the MR environment. An important point to be noted is that this guideline of having 2 people working together in the healthcare setting was actually recommended by the Veterans Health Administration, the VA, and I commend them for doing so. Um, so it's really good. Now we move on to the next discussion point, which is about casual ableism and microaggressions faced by BIPOC, deaf, or hard of hearing workers in the professional setting. In particular, the spotlight on their speech patterns and accent. Let us define ableism first. So, ableism is a discrimination of and social prejudice against people with disabilities based on the belief that typical abilities are superior. So, at its heart, ableism is rooted in the assumption that disabled people require fixing, and it defines people by the disability. Now, microaggressions are brief and common daily verbal, behavioral, and environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative, orders, slights, and insults towards deaf people that establish, reflect, and reinforce the dominance of the hearing majority. So it's microaggressions are most likely like it's everyday language, everyday casual conversations that you may come across when conversing with your coworkers, employers, um, and anyone that you're around with while working at the hospital or at the workplace in general. So some examples of microaggression are: "I'm so lucky I'm not deaf." "Your English is so good for a deaf person." A deaf person cannot lead a university. And my personal favorite, "You speak really well for a deaf person." I have heard that thousands of times, like multiple times over the course of my career. As you all know, I host my own podcast series, Let's Talk MR Safety with Lexie. So I've had a lot of top radiology and healthcare leadership in my podcast, and I've spoken to them there. In the comment section of our podcast and webinars, the number one comment that I see is that you speak really well for a deaf person. So there is the assumption that if you're deaf, then you're mute. And if you're deaf, and also there's one assumption that if you're deaf, you are dumb and you cannot really do a lot of activities of daily living, like cooking, driving, studying, working in healthcare, or working anywhere in general. So, such microaggressions, they seek to infantilize deaf people. It's an infantilization is like it's defined not allowing a person with disability to perform actions that they're perfectly capable of doing. So it's like, you cannot work in the kitchen. It's you may not be able to hear other people. You cannot drive. How will you hear people who are like trying to direct your attention by sounding the horns, stuff like that. So it's so those microaggressions, they seek to alienate, exclude, and also infantilize the deaf and hard of hearing people. So I would say, don't use sugar-coated, politically correct terms that mark the importance of labels and terminology, and not deny the importance of disability. For example, you cannot also say handicapable, differently abled, or height challenged, because they are also infantilizing and demeaning terms. So they are all kinds of microaggressions that we face every day in the healthcare setting. And I personally, I've from time to time, during over the course of my clinical rotations, I've faced that personally. But it also depends on the work environment, the corporate culture. For instance, there were two clinical rotations that I worked at, where I faced a lot of ableism and microaggressions and was passed over for opportunities. But then I also had the opportunity of working under this excellent manager of mine, a radiology manager. His name is John Libel, and he told me that he would be watching this live stream today. I hope you're there, John. So John and my supervisor David Nem, they were the most progressive individuals that I've had the honor and privilege of working with. They actually went out of the way to provide accommodations for me. They would use as a CAT, like communication access real time translation, on their phones and everything, and like speech to text. Like if they had any instructions for me, the phone would translate their speech to text, and I would be able to understand what they were saying if the MR environment was really noisy. And they also went over and above, and tried to learn sign language, which is the American Sign Language, ASL. And they used to sign to me a lot of time, and we used to practice ASL. So it really depends on the work environment. Some people go out of the way and don't really. There's no culture of ableism or microaggression. You don't see that. But there are also workplace and some way the culture, the workplace environment itself is toxic. The workplace culture is toxic, and you might see a lot of ableism and microaggression. I've had, but now, I mean, after all these years and after facing all of that, at this point, I would say I've come really far, and have had the privilege of working with some really progressive and broad-minded individuals who see me for me, and who understand that I have a lot of potential. I have a lot of also untapped potential, and I could do so much more despite being deaf and hard of hearing. So I'm thankful for all of them, and yeah. So now we go to the next discussion point. How do we eradicate racial and ableist barriers while working towards equity and inclusion in the healthcare setting? So the first and foremost, the most important thing would be the provision of appropriate accommodations. This is especially important because the Americans with Disabilities Act, the ADA, it requires employers to provide employees with disabilities with appropriate accommodations to perform their job. And also, it has been cited that the sign language, the American Sign Language, British Sign Language, or sign language applicable to the continent or the country you are from, it is a fundamental human right from which it is possible to achieve all other human rights. So basically, it kind of points to the fact that if you are willing to accommodate to the deaf and hard of hearing or any individual with disabilities, it actually helps exercise all other human rights. that they deserve or have the right to. So some of the other appropriate accommodations that could help remove racial and ableist barriers are visual and tactile operating systems in place, and the provision of looping in buildings for hearing aid and cochlear implant users. So visual and tactile operating systems would be something like, for visual pages, like any alarm systems which has, visual and blinking lights, and any tactile operating systems. It's something like, you could feel and touch, and in place of anything that is auditory. um, uh, and if you have like, instead of audio phone calls, video phone calls, all of those are form part of visual and tactile accommodation. And let's go talk about looping in buildings for hearing aid and cochlear implant users. Like I mentioned before in this talk, the hearing loop, that is sometimes called an audio induction loop, is a special type of sound system for use by people with hearing aids. This hearing loop provides a magnetic wireless signal that is picked up by the hearing aid when it is set to T, or the telecall setting in the hearing aid. So this hearing loop, it consists of a microphone to pick up the spoken word, an amplifier which processes the signal, and is then sent through the final piece, the loop cable, a wire placed around the perimeter of a specific area. It could be a meeting room, a church, a service counter, or and like any cubicle or office in the healthcare setting that you are at when you're not caring for patients in maybe the more surgical or areas where you're doing medical imaging, scanning, and all of that. And so this loop acts as the antenna that radiates the magnetic signal to the hearing aid, and it actually removes all background noise, so you could hear your coworkers, colleagues, and patients, and well, more clearly in a clearer manner. The other accommodations that could be provided are computer training programs to accompany a classroom setting, or you could provide the hearing impaired workers, I mean the deaf and hard of hearing workers, with translators in training sessions and meetings. Any films or educational programs that you offer, it should have captions in them, or a written version of the script, so that the deaf employees can follow along with. There should be more of web-based training or computer-assisted note takers that can participate in group meetings to translate for the deaf and hard of hearing employees. And for the co-worker and general communication, they should be the provision and utilization of name tags for introductions, because I mean we cannot really hear names or everything, uh, or like the title that they hold right away. So if you go a little bit one step more and provide name tags for introduction, that could help solidify co-worker relationship. There should also be a provision of more on-site sign language interpreters, um, which could just help, add to the overall communication for the deaf and hard of hearing in healthcare and overall workplace settings. There should be more educational and awareness training programs. I would say we should incorporate bi-weekly or quarterly training with regards to disability education at the employee, HR, and corporate levels. Like too many times, it has been seen that HR is not really aware of deaf candidates or deaf applicants. And I think if there are more training programs, more awareness programs for them, then the deaf and hard of hearing candidates would not be passed over for job opportunities that they are very much and highly qualified for. And also at the employee and corporate level, such programs can help them understand how to provide accommodations for the deaf and hard of hearing when they are doing patient care, or when they are trying to learn how to do the job at the workplace. It just all these training programs can just build more of a cohesive working relationship, and it can lead to like increased positive patient outcomes, and also better like more positive output for the whole workplace culture. It can actually remove the toxic workplace culture that is actually rampant in most places in and around the world. And I think a lot of this, the accommodations, the awareness programs, all of this can come if there are a certain state or federal grants, funds, or scholarships set aside to allow for the employment of deaf workers in the healthcare setting, and also educate those who are not disabled. Now, the ADA prohibits employers from discrimination when hiring, but though they can't discriminate, most employers, what they do, they still resist hiring deaf workers because of the cost associated with special equipment such as text telephone equipment, the vibrating visual pages, the caption videos. So a lot of times, I mean, even the HLA and AMPHL, which I'm part of, they always cite the same thing: funding. That's the main issue here. And if we could just get federal or state level assistance, more of that. Yes, there are some programs that do have federal or state level assistance in place, but I don't think they have been as effective. And I think there should be a little bit more of a quota set aside for the deaf and hard of hearing. It could then eradicate the ableist and employment barriers. And then lastly, I'm going to direct you to a list of organizations and for people who are the deaf and hard of hearing. You have a lot of them. You have Able Data, you have Adara, so you have American Speech Language Hearing Association, ASHA, the ALDA, which is the Association of Late Deaf and Adults. I also have some organizations here for like the National Black Deaf Advocates, which is catered Black deaf and hard of hearing individuals. I also have the Sacred Circle, which is geared towards the Native American deaf and hard of hearing healthcare workers or workers in general. So if you contact me, I can direct you to them.
Hey, Lexie?
Yeah.
Would you mind sending me those links of that you have on those slides? And I can put them in all of our channels. Because it's a little hard to see those links on the screen.
Yes, can you please repeat that?
Yes. I'm going to put it in the chat.
Yeah, all right. Yes, I'm going to send you the links. Like maybe through email.
Yes.
Yeah. All right. So well, that about brings to an end my talk. It was an honor and a privilege to be talking about disability and ableism in healthcare on the C3 virtual summit on this platform. On an ending note, I want to thank all my colleagues, all the frontline healthcare workers, all my colleagues at the front lines who are striving and struggling to take care of the COVID patient in this deadly coronavirus pandemic, as we see the rise of the deadlier second and third wave that are coming. I want to thank all of you. I see you every day taking care of the COVID patients at TCU, relentlessly fighting for, for everything, for PPE, for the patients, for everyone. So thank you so much. And I would want to call upon the healthcare organizations, and I would really want to highlight this significant fact that along with accommodations, the important thing at this point is please help us, all the hospitals and facilities and organizations that we are working at, please help us in obtaining PPE, because a lot of us are having to reuse them, and we are really a little bit far away. Though there's a vaccine now, and we are moving towards a positive pace towards maybe ending this pandemic. There's still we have still got a long way to go, and there's no testing yet, so we are having to reuse PPE, and many times often our masks fall off and everything, and many of us have not been tested yet. So please help us in obtaining PPE. And also I want to once again thank all of you for all that you have done in providing me emotional support and motivation as a struggle to survive. the tough, hard of hearing radiology healthcare professional. Thank you so much, everyone, and thank you, Dr. AJ.
Thank you so much, Lexie, for this amazing talk. In spite of technical difficulties, we really made it work. And I'd love to hear from those of you who are listening now or listening later or watching this later. I'd love to hear what you thought of this session. So please fill out the survey. That's the ticker is on the bottom of the screen, www.bit.ly/C3EB survey. So we know how your experience has been. And that's it for us. We are going to take a very short 5-minute bio break, and we'll be back right at 4:30 with our next session with no technical difficulties, hopefully. But again, thank you so much, Lexie, and thank you to all of our partners who have been such a huge part of helping us walk this walk. So thank you all.
Yeah.